And myself, Dr. Satya Vijay. Today I'm going to present a case of breast lump. A 27-year-old female from Balia, Hindu, housewife, came with a chief complaint of a lump in the right breast since 4 months. And she has noticed an ulcer over the right breast since for 15 days.
What?
Patient was apparently normal 4 months back, incidentally noticed a single lump in the lower and inner aspect of the right breast while bathing. Initially, it was roughly 1 into 1 centimeters. It has progressed to a present size of roughly 4 into 4 centimeters. The lump was painless, and since past 15 days, she noticed an ulcer roughly less than 1 centimeter of the lump at the biopsy site, which she underwent at an outside hospital without any discharge from the ulcer. No history of any nipple discharge. No history of similar swelling in the other parts of the right breast or both armpits, opposite breast, and in the neck region. No history of swelling or heaviness in the both the arms. No history of anorexia or weight loss. There is no history of evening rise of temperature. There is no history of cough, chest pain, or hemoptysis. There is no history of any back pain or hip pain or shoulder pain. And there is no history of any headache. Coming to the past history, she has no comorbidities, no history of any tuberculosis. She doesn't give any history of connective tissue disorders, and no history of chest wall irradiation, and there is no history of similar breast disease or biopsy or trauma to the breast. Coming to the personal history, she takes a mixed diet, and there is no history of smoking or alcohol intake. There is no history of any drug or food allergy. There is bladder and bowel habits are normal. Coming to the menstrual history, she attained menarche at 12 years of age, married at 26 years, nulliparous, cycles are regular 3 to 5 days, and 28 to 30 days cycle. Duration was normal with average flow. LMP was 25/5/22. There is no history of any OC pills intake. Coming to the family history, patient mother expired at the age of 50 years. When she was diagnosed with malignancy, they couldn't classify what type of malignancy or what could they tell is she had abdominal distension, and what they all know, it was a terminal stage for which treatment has been started, but she died within 3 months of the diagnosis. There's no documentation available of the history. And also the paternal uncle expired at age less than 50 years. They didn't know the exact age, but they knew it was less than 50 years. And he was diagnosed with jaundice and weight loss, and also suspected malignancy, and he died roughly 6 months after the diagnosis. No documentations were available. No history of similar complaints of any other family members. No history of any hereditary or genetic mutation known in the family. There's no history of any tuberculosis in the family members. All the siblings are in the good health, and she's born out of a non-consanguineous marriage. This is a pedigree chart showing the proband, she's aged at 27-year-old, and her mother died at age of 50-year-old, and her paternal uncle has died at the age which is less than 50-year-old. Coming to summarize my clinical history, 27-year-old female, premenopausal, nulliparous, with progressively increasing right breast lump for 4 months, which was painless, later associated with ulceration at the biopsy site. Coming to the family history, there is a first degree related to diagnosed with malignancy at age of 50 years, and another second degree related to diagnosed with malignancy at age less than 50 years. Query gastrointestinal origin.
So, what is your diagnosis at this point of time?
Sir, my diagnosis at this point of time will be malignant breast lesion because of short duration of history and a family history of malignancy, sir.
So, short duration of history goes in favor of malignancy.
Sir, with the overlying development of ulcer over the skin, yes, sir, and it is a painless and no any features of uh, any trauma or anything, sir. So
in a 27-year-old female who had been biopsied elsewhere develop an ulcer after the biopsy, you will diagnose it as a malignant lesion of the breast.
with the family history of malignancy, both maternal and paternal side, sir. General examination, the patient was explained regarding the examination position, consent was taken. She was examined both in recumbent, semi-recumbent, and sitting position in a well-lit room with a female chaperone in present. She's conscious, coherent, BMF 21, BP of vitals were stable, respiratory rate of 13 per minute, thoracoabdominal. There is a right axillary lymph node present, rest no lymphadenopathy elsewhere in the body. Coming to the examination of the breast on inspection, coming to examination part, coming to the nipple examination, the right nipple is at a higher level compared to the left, and there is no retraction, fissure, or discharge or ulcer from both the nipples. The areola, there is no ulcer, eczema, fissure. On leaning forward, both breasts are falling equally, and on arms raising position, the inframammary crease is seen on both sides were normal. On examination, bilateral arm, axilla, and supraclavicle regions were normal. On palpation, the breast size was 34 dd for both the breasts, and there is no ptosis. On the left breast and axilla, the normal side was there was no abnormality found on the left breast and axilla. Coming to the right breast, there is no local rise of temperature and it is non-tender. A single 4 into 4 centimeters hard, well-defined lump with irregular margins was noted at 4 o'clock to 5 o'clock position of the lower inner quadrant of right breast, 2 centimeters away from the nipple areolar complex. The lump is fixed to the overlying skin and it is fixed to the breast tissue. No fixation found to the underlying muscle or chest wall. A single 0.5 into 0.5 centimeter ulcer irregular was noted over the lump in the lower inner quadrant of right breast, surrounded by irregular circumferential indurated erythema around the ulcer. Edges were raised and floor was covered with slough. The ulcer was tender on touch and there is no bleed on touch present. Base is indurated. Ulcer is fixed to the underlying lump. There is no retraction or discharge seen from the nipple palpation. On right axilla, 1 into 1 centimeter hard mobile non-tender node is palpable in the central group. Bilateral supraclavicular lymph node, there is no abnormality noted. Systemic examination is normal.
Do
Her
you have
abdomen
a
is normal.
picture of the ulcer?
Sir, this is the one, sir.
Where is the picture of the ulcer?
Sir, in the upper inner quadrant, sir.
Show the ulcer showing the everted edges, slough covered base.
Yes, sir. I mentioned it, sir.
You mentioned it, but show it.
Sir,
We can't see it.
it's a small 0.5 to 0.5 centimeter ulcer, sir, actually.
We just see a
Uh,
mark. That's all. It's something like a scar. Nothing else is visible over there.
yes, sir. This is the maximum I could zoom, sir. Yeah.
Yeah, this is the needle point entry.
Sir, it's indurated, sir, with raised edges are also present, sir.
Was this the site for of FNAC?
Yes, ma'am. It was site for the true cut biopsy, ma'am.
The site for true cut biopsy.
Yes, ma'am.
No, then it's not an ulcer.
Not an ulcer.
It's a
And there
local
are,
hematoma and inflammation.
and we can't see any erythema or whatever your sign of inflammation that you are trying to show. Nothing is visible over there. There is no
So,
erythema, no edema, no erythema. Nothing is there.
no edema, sir. Just erythematous indurated thing, sir. It was on palpation also. It was indurated. Sir.
Is it free?
No, ma'am. It is fixed to the underlying lump, ma'am.
What about rest of the skin?
So rest of the skin was normal, sir. In all the quadrants, there is no engorgement,
Rest of the
edema,
skin
skin.
is free. Rest of the skin is also adherent to the mass, or it is free from the
No,
mass.
sir. 0.5 centimeters around that ulcer was adherent to the underlying lump, sir. Systemic examination was normal. Per abdomen and per vaginal and per rectal examination were normal. Coming to the case history, a 27-year-old female premenopausal nulliparous with a progressively increasing right breast lump, which was painless, and a 15-day onset ulcer at the biopsy site, with a family history of malignancy in the first degree diagnosed at the age of 50 years, and another second degree related to diagnosed with malignancy at age less than 50 years. On inspection, the right breast appeared larger with fullness in the right lower inner quadrant with an irregular ulcer over it, and the nipple is at a higher level. On palpation, the lump was hard, fixed to the overlying skin and to the
In
breast.
summary, you don't say all this inspection palpation separately. It should be a 3-4 line summary only with positive findings.
With a right single mobile axillary lymph node, ma'am, with no evidence of any systemic manifestation. With a provisional diagnosis, I would like to have it as a locally advanced malignant lump of right breast, CT4B N1M0. And the patient has come to us with a corneal biopsy showing invasive ductal carcinoma, grade 3. And she had an ultrasound of both breasts, which was not a clear report. It just showed a 48 into 40 well-defined echogenic mass. With the final diagnosis, I would like to tell as a locally advanced invasive ductal carcinoma of right breast, CT4B N1M0, grade 3. IHC I required for the staging, and I am suspecting a hereditary component in this patient. She is in a premenopausal status with a breast size of 34D. And, I would like to do an IHC status, routine blood investigation, metastatic workup. It can be either a PET CT or a combination of CCT, abdomen, thorax, and pelvis with a bone scan. I would also like to provide her with genetic counseling with genetic testing, address her fertility, and also a pregnancy test.
Okay. Which genetic testing will you do?
Sir, before going for the genetic testing, I would like to counsel her regarding the genetic testing and probability of her having the germline mutations. And I would like
Which
to,
germline mutations or which syndromes are you suspecting?
yes, sir. It usually differs, sir, if patient doesn't have any significant known pathogenic or likely
Can't you
pathogenic.
directly answer to the question?
Yes, sir. A comprehensive genetic testing, sir.
So, what are the syndromes or what are the genetic diseases that you are suspecting?
Yes, sir. It mainly covers BR in the hereditary breast cancer ovarian syndrome, sir, like BRCA1 and Leaf-Romani syndrome and Peutz-Jeghers syndrome,
What is
and
the
Cowden syndrome.
possibility here?
Sir,
You have taken a
possible.
family history, you made a pedigree. Now
Yes, sir.
give me a syndromic diagnosis.
Yes, sir. I
Which
would
syndrome
like
are you
to,
suspecting?
sir, I'm suspecting BRCA1 and Lee-Fraumeni syndrome in this, sir, because of onset of age less
Both?
than.
Both?
Yes, sir. Because in coming to the BRCA1 testing criteria, the age of her is less than.
I didn't ask you that. I'm asking
Yes.
you, are you suspecting both Lee-Fraumeni and BRCA?
And also it can be there are other chance of other syndromes also, sir.
No, I'm asking you,
90%.
what do you suspect?
Sir, I would like to go for initially BRCA1 and BRCA2, sir, because 90% are associated with BRCA1 and 2.
Which is the commonest syndrome causing breast cancer?
Sorry, sir. I think it was BRCA1 and 2.
So if it is BRCA1 and 2, how do you explain her uncle having a GI malignancy?
Sir, actually, I couldn't get a proper history from which, so I can like we can't
See,
conclude a single.
you are making a diagnosis based on that history.
Yes, sir.
You are taking treatment decision based on that history. And now you're saying that you were not able to take a proper history.
Uh,
This is contradictory.
that's why I wanted to go with a comprehensive genetic testing, so not specifically pertaining to BRCA1 or 2.
So what comprehensive genetic testing will you do?
Sir, it includes most of the common genes involved in the hereditary breast cancer syndrome, sir, which usually include BRCA1 and 2 and TP53, STK11, CDH1, and PLAB1.
So would you like to get it done before you start the treatment or after the treatment?
I would like to start if the patient is willing for a genetic testing, I would like to start before the treatment.
So T4B N1 and you are going to wait for the genetic testing results to start the treatment.
No, sir. It will be a simultaneous. I would like to start with a neoadjuvant chemotherapy in this patient. The genetic testing will take time. Like I would not wait for the result test to come, sir.
So how will you address fertility if you are planning to give neoadjuvant chemotherapy?
Sir, patient will be counseled with the help of a fertility specialist. And if she is deserving for fertility, according to a few recent RCTs, she will be started on GnRH analogs before starting chemotherapy as they claim to preserve more fertility. And she will also be counseled regarding the.
Satyavijay, you don't even know the receptor status at present.
Sir, it's GnRH analog is not for the treatment purpose, sir. It is shown that if it is given before starting either neoadjuvant chemotherapy or adjuvant chemotherapy, it helps in preserving the early starting of menstrual cycles and fertility, sir. Not for the treatment purpose, sir.
So that is how you address fertility.
No, sir. Fertility, I would like to counsel her regarding the chances of decreased fertility. It can be secondary to.
So how do you preserve fertility? She is married just for 1 year. She is 27
Yes,
years.
yes, sir.
So if she
She'll.
wants to have a baby later in the life, what are you going to do for now? How are you going
Uh,
to address it?
Yes, sir. Sir, if
Before
in case.
starting your new adjuvant, what are you going to do? Do you have a plan in mind that I am going to do this?
Yes, sir. Yes, sir.
What plan do you have?
Sir, actually, if we take into consideration the genetic testing results, if she's a carrier of any pathogenic or likely pathogenic, I would like to advise her prenatal implantation genetic diagnostics so that it will not be spread to the next generation. Or sometimes some of the hereditary disorders are autosomal recessive. So even the partner needs to be tested so that both are not.
I think you're totally confused. How are you going to help her, in conception later?
Ma'am,
How to go about it?
yes, ma'am. I'll give her the option of oocyte preservation, ma'am.
Is she married?
She's married, sir. Married for a year, sir.
Still, you would give her a option of oocyte preservation.
Or embryo preservation, sir. Embryo
So what
freezing.
are the different ovarian preservations you have? Like, what can you preserve?
Sir, oocytes can be preserved or embryo preservation is present. Sir, oocytes are preserved in unmarried females and embryos are in married females. Embryo freezing is done.
Why so? Why embryo is preserved in married females and why oocyte? I mean,
Embryo has a better chances for viability compared to oocytes. Sir.
So can you tell me the sequence of events that what this is you are going to do first, then you are going to do this second, then you are going to do this third?
Yes, sir.
Yeah.
Sir, initially, if the metastatic workup is confining to be a locally advanced breast cancer, I would like to give her a option of neoadjuvant chemotherapy. Before starting neoadjuvant chemotherapy, I would like to give her the genetic testing, counseling, and genetic counseling and testing. And if she opts for a
it's too hot here. Let's sit
if she opts for a breast conservative surgery before starting neoadjuvant therapy, I would like to
clean.
advise her regarding the clipping of the lesion.
I thought I'll vacuum it.
And
All that there.
after neoadjuvant chemotherapy will be based on the type of IHC she has got it, sir. Based on the IHC, whether it is HER2 positive or HER2 negative, based on the chemotherapy will be based on. And according to the chemotherapy response rate after completion of defined cycles, and if she's planned, she can be planned for BCS, sir, if she has good response. And after good response, she can be planned for adjuvant radiotherapy. And adjuvant systemic therapy will be based on the pathological complete response and also on the pre-adjuvant chemotherapy. The genetic testing showed if patient has any pathological or likely pathological variant, she will be told about the risk management things, and the relatives also will be informed regarding the risk and their risk management surgeries or chemopreventive strategies.
Suppose she comes out as BRCA positive. What are you
Yes.
going to do? How is it going to change your management?
Sir, she comes BRCA positive, and neoadjuvant chemotherapy will be based on mostly IHC kinds, whether it is HER2 positive or negative. But she will have an option of olaparib as an adjuvant adjuvant systemic therapy, sir, post.
What else is going to change?
And sir, if she's a BRCA positive, she will be. It's a relative contraindication for the breast control BCS surgery, sir. And if still she is opting, we can go for BCS as the mortality doesn't change, only the recurrence rate increases. And she will also be advised about bilateral salpingo oophorectomy. Or if she's denying for the bilateral salpingo oophorectomy, she will be kept on regular monitoring of either TVS with the CA125. And if she has opted for BCS, she will be serially monitored with annual MRI scans.
So what are you going to do to the contralateral breast?
Sir, contralateral breast, she has to yearly, if she's opting for BCS, she has to undergo annually MRI scan, sir, for screening MRI. Sir, I will give her both the options, sir. If it will be the patient's choice whether to go with the prophylactic surgery or she would like to have a BCS with serial yearly monitoring screening. Sorry.
So you mean to say results for both are same?
No, sir. Prophylactic mastectomy has shown to decrease 90% decrease in the contralateral breast, but it is a patient's choice to opt for the treatment. I'll tell the benefits of.
So you are going to give her two choices, one of which is inferior to other.
Both the things, the survival rate is similar, but recurrence rate is higher in the preservation surgery.
Why not bilateral subcutaneous mastectomy with reconstruction?
Sir, the subcutaneous mastectomy for this patient because of I would like to see the response, sir. If already skin has been involved in this patient.
Actually, is the skin involved?
Yes, sir.
Do you have an MRI of the breast done after the biopsy?
No, sir. No, sir. I would like to, if patient is planned for a conservative surgery, I would like to have a MRI of breast, sir, because it will be helpful for assessing the response to the chemotherapy. And also as she's
But I don't see it in your workup.
No, sir. I would like to, this one I wanted to tell after explaining the counseling to the patient, sir. If she's opting for a bilateral mastectomy, there is no role of MRI, sir. So that's why after
Why
advising to
her
the patient.
stage, if this ulceration is because of biopsy, her stage will change. Her prognosis will change.
But the surrounding skin was also like
Inflammation. And if you are saying that there are signs of inflammation, then it becomes 4D, not 4B.
sir, inflammation is less than 1/3 of the breast, sir. Like
Doesn't
so,
matter. Doesn't matter.
inflammatory only like
Now
if it
my
is involved.
question, the question is the
Yes,
inflammation result of a intervention or it is an inflammatory carcinoma are you dealing with?
sir. Intervention, sir, not inflammatory, sir.
So if the ulcer and the inflammation is because of intervention, then how does it changes her staging?
So actually, like when she came for the clinical examination, that not just the ulcer, the adjacent skin was also like fixed to the underlying lump. So I thought it was that biopsy which like helped in fastering the spread of the tumor to the skin.
No, I think you presented it to be an everted and all these edges and like that.
Yes,
So
ma'am.
you very
Yes,
much
ma'am.
meant that the skin has been grossly involved with cancer.
Yes, ma'am.
You didn't think it was biopsy induced inflammation and infection.
Ma'am, the lump was very much beneath the skin, so I thought the
Doesn't matter
biopsy.
if somebody has done a very damaging biopsy, all these things can occur.
A hematoma formation, abscess formation can always take place. Skin ulceration can always take place if the proper precautions are not taken during the biopsy. And still, you are not thinking of doing any imaging of the breast to do this staging.
So what if I still think it is a locally advanced and if she's preferring for a neoadjuvant chemotherapy, I would definitely like to have a MRI of the breast, sir. But that's why, as I didn't know the further treatment plan, if genetic testing comes positive,
Which
then
I also don't see any investigation for staging of axilla.
sir, ultrasound of axilla also has to be done, sir. Uh,
So why is it missing from your list?
Ultrasound of the axilla with the FNAC of the suspicious lymph node will be
If that
required.
lymph comes positive, what else you have to do?
Sir, if that lymph node, the simultaneous clipping of that lymph node can be done. In case if we are planning to do
See,
a
it's nothing can be, so everything can be done. What is to be done? That is what we are concerned with. What can be
And
done is not an issue here.
and if she's BRCA positive, how will you check the other breast? She's only 27 years. Will you not do an MRI?
yes, ma'am, MRI will be a option, ma'am.
Irrespective of whether she opts for a prophylactic surgery or not?
I would like I was about to tell ma'am in the follow up, like she'll be always having a MRI of the
Not
breast because
follow up before the
no,
What
treatment.
follow up?
sorry, ma'am, like for
Yeah.
the further, like I didn't know like how the further management will go from me. That's why I didn't mention them. It was in my mind to tell like MRI was
No, no.
sufficient.
When Professor Pandey asked you categorically, how will you manage the case if she's BRCA positive, you did not say though. So.
And to be honest, nobody is going to wait 1 month to start the treatment and wait for the BRCA results.
No, sir. I will not wait for the results, sir. Neoadjuvant will be
So
started based
that
on.
is why I ask, what are you going to do first? What are you going to do second? What are you going to do third?
Yes, sir. If neoadjuvant is my plan, I would like to go with the MRI of breast, sir. So for seeing the evaluation of response
What else?
sir, it will be pre neoadjuvant therapy, clipping of the main lesion and the suspicious lymph node will also be done, sir. Like patient will be monitored for the response to the chemotherapy. And,
That will be only after giving the chemotherapy.
yes, sir.
Question is, before you give chemotherapy, what else will you do? Fertility preservation नहीं करोगे?
Sir, it was being addressed, sir, regarding addressing. It was addressed, sir, regarding fertility. She will be like counseled with a
So
fertility
that is
specialist.
Dr. Tarun asked, how will you do it? You are not giving your answer. You have to say, if I am planning for a new adjuvant therapy, I'll do this first. After that, I'll do this. Then I'll do this. Then I'll do this. And then I'll take the patient for new adjuvant chemotherapy. The things you will do. You are not telling what are the things you will do. You are not imaging the breast. You are not imaging the axilla. You are not planning the fertility preservation, either the oocyte or the embryo. You are doing nothing. You are simply starting chemotherapy. Do you understand?
Yes, sir.